Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center reporting for the week of March 25th, 2024. Following an update on COVID, flu, and RSV, I'll provide a status update on measles and review monoclonal antibodies, including the latest approval for COVID prevention. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there's still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Overall, COVID-19 indicators are heading in the right direction. COVID wastewater has been considered low nationwide for 2 weeks in a row now. But of course, as usual, it varies depending on where you are. So as we can see from this map, first off, there are entire states that don't seem to have any reporting going on, so no dots in the entire state, and some that really have very few, but certainly you can see on the coasts and some other regions, there are quite a number of sites reporting, and the warmer colors indicate a higher concentration of SARS-CoV-2 in the wastewater. So if this is something of interest to you, you can try to find a site that is reporting near you and stick with one, look at it over time. That will give you a good sense of what is going on in your area if you're interested in that. Taking a look at weekly new hospital COVID admissions. These continue coming down, which is great. We're now just over 10,000 hospital admissions for the week ending March 16th. So still a lot of people being hospitalized, but definitely heading in the right direction for the 10th week in a row that we've seen hospitalizations decreasing. And February 24th is the 6th week in a row that we are seeing declining COVID deaths. So this is also good news. And we hope to continue to see cases, hospitalizations, and death coming down. We'll just keep an eye on it. No news is good news on the variant front. We're still really only dealing mainly with the JN.1 variants at this time. Taking a look at RSV, this continues to come down nicely. Hopefully we'll be able to mark the end of the RSV season pretty soon. And flu is finally all appearing to come down. It's kind of dragging on a little bit here, this flu season. We're usually not worrying too much about influenza as we head into April, but it definitely can happen. It's still considered flu season. But finally, we're seeing even the influenza B now coming down. That's that green line there that up until last week or so, it was still heading up. But as of now, A and B and overall cases all seem to be finally coming down. So hopefully it will continue to do so. Hopefully we can soon be done with so-called respiratory virus season with respect to flu and RSV, but SARS-CoV-2, we know we can continue to expect to be dealing with it. Of course, it will go up and down. So hopefully things will continue to come down and we'll have some months of low transmission before it heads back up. New hospitalizations with flu are coming down nicely. So far this flu season, there have been an estimated 340,000 hospitalizations, 21,000 flu deaths, and 121 of those were pediatric deaths. And to look at deaths from the 3 respiratory illnesses altogether, I think this chart continues to be a visual that kind of helps make it plain. COVID deaths are the orange, influenza deaths are in blue, RSV deaths are in purple. So we're kind of still in the time where we do see flu deaths, much fewer RSV deaths, but certainly COVID deaths continue to be an issue. So even when all 3 viruses are giving us some trouble, COVID is continuing to give us the most trouble, causing far more deaths than influenza and RSV combined, literally every single week of the year. even in so-called respiratory virus season, where we are grappling with influenza and RSV deaths. And of course, there are times of the year, as we could see there, where flu and RSV deaths go down almost to zero, yet we're still dealing with COVID deaths. So this is kind of the reality at this time, but we'll see how things continue to evolve. And now I want to talk a little bit about measles. So we are definitely grappling with increases in measles in a lot of places around the world, including places that previously had eliminated measles. So in last month, the World Health Organization put out a news release regarding the European region, which had a sharp increase in measles cases in 2023. The European region includes 53 member states throughout Europe and Central Asia, and they saw a 45-fold increase from 2022 to 2023 in measles cases. And they put out a news release saying that rapid measles outbreak response is critical to protect millions of vulnerable children. Now, 33 of those 53 member states had achieved measles elimination as of 2022. And remember, elimination of a disease or infection is when specific and deliberate efforts result in getting the disease or infections down to zero in a defined geographic area. And measles is something that we were able to eliminate in the United States about 2 decades ago. And 33 of the 53 in Europe, at least by 22, had achieved elimination status. Now, the thing about elimination status is that it requires continued effort so that transmission is not reestablished. And that is really what we're concerned about when it comes to measles, and for that matter, polio or anything else that we've managed to eliminate through vaccination. Because if we don't maintain those high vaccination rates, then we risk losing that elimination status, which means that we would be facing the risk of transmission being reestablished or even sustained. And so that is what we seem to a little bit be seeing, that we're facing an increased risk of this because vaccination rates are going down. And we know that into 2024, several of these European countries continue to have challenges, including the UK. In fact, the UK Health Security Agency declared a national incident this past January over their rising cases. So measles elimination is a great achievement, but it is a fragile achievement, and it is fragile here in the United States as well. So these are just some of the headlines from just this month, March 2024, where we are seeing increased cases. And so far in 2024, just not even the first 3 months of 2024, we already have more confirmed measles cases than we did the entire year of 2023. Last month, I reported about the outbreak in Florida, and this month we are seeing reports of cases in other states. A few of those appear to be linked to people visiting Florida, and we know that Florida is a popular spring break destination, so we will just continue to keep an eye on that. And if you're interested in the Florida outbreak and how that is being handled, I spoke on that in a briefing that is linked in the post. But so far as of March 21st, we've got a total of 64 confirmed measles cases in the United States in 17 jurisdictions. You can see those states listed out here. And the link to this measles surveillance page is in the post as well. But we can see that overall the trend is going up. And so this is not so much about the actual number of cases, but it is true that we only had 58 in the entire year of 2023, and 2024 is, off to a strong start for measles, with 64 cases in under 3 months compared to 58 the entire year last year. But still, this is more concerning, not just the absolute number, but because of the direction that we're going and also because of why we are going there. And so I briefly just wanted to mention this morbidity and mortality weekly report from earlier this month. And it was regarding the measles outbreak that occurred in Cook County, Illinois in October and November of 2023. And what they're sharing here are the results of their outbreak investigation and the outcomes that came from it. And so I just wanted to briefly highlight a couple of those things. First is that they did seem to move quickly and get a number of children vaccinated or treated with what we call post-exposure prophylaxis. So that is after an exposure for someone who is not protected, within 72 hours, we can give them the vaccine or treatment to prevent them from progressing, from actually developing the disease. And this is very important because it can dramatically reduce the risk of developing measles if you catch it in time. So they focused some effort on 19 children who had been exposed and were not protected. 13 of them were under 1, so they're too young to be vaccinated. 5 were immunosuppressed. 1 was over 1, but they were still unvaccinated. So that comes out to 19 children they were focusing on, and they ended up being able to treat 15 of them with post-exposure prophylaxis. So this is super important because this is at least going to reduce the risk of a bad outcome. And this is exactly what we want to be doing when there is an outbreak, is really hurrying up and figuring out who is at risk and then seeing what we can do to get them treated. This takes a lot of effort. This takes a lot of focus. This takes a coordinated response, but this is what we need to be doing. And unfortunately, I think that public health departments and treating providers are going to have to brush up on this because unfortunately we seem to be faced with more of it now. The main thing I wanted to highlight from this report is, well, we know that measles is highly contagious, but through this case investigation and contact tracing, they were able to determine that measles actually spread between unvaccinated children who lived in the same apartment building, but on different floors. The families they don't know each other. They speak different languages. They're from different backgrounds. They both independently stated that they had no contact with one another. The apartments did not have any shared ventilation, thank goodness, because then probably the whole building would have been, really exposed. But they did have a common entrance and also common laundry facilities. And all in all, in this community outbreak, 5 children developed measles. And all of these children were eligible but had not received MMR vaccines due to different barriers of sorts. And this apartment building situation of people living on different floors is certainly concerning, but it kind of confirms what we already know. Measles is extremely, extremely contagious. And if you're unprotected and exposed, then your risk of developing measles is very high. It's like 90%. The report also talked about the very expensive costly nature of having to identify and treat measles patients. So it really is not just a you do you individual situation. You can get other people sick. You can cause babies to become deaf or have neurological problems. You can also place a burden on the public health system and the hospital system for something that is really completely, or at least 97% preventable with a vaccine. 2 vaccines, they've been around forever. And it's just a little bit difficult to understand why anyone would be declining this vaccine. So the most important thing I want to say is that if you've received both doses of the MMR, or if you had measles and survived, then you should be protected, although I think, unfortunately, the long-term effectiveness of all of this is being tested at this moment. So what we may have thought was a higher or longer duration of protection, we may just be getting ready to find out if, what the caveats are to that, because now we're being tested. Before, even if someone's immunity had kind of waned over time, or maybe they just didn't mount a good response and we didn't realize it, they weren't getting exposed because measles wasn't really transmitting from person to person, and it would be only on the rare occasion that someone brought it in or imported it in from another place. But we'll find out. The guidelines really haven't changed yet in terms of checking immunity and things like that, unless you're a healthcare worker. But I do think this is something that we're all going to be examining now because we don't want to take anything for granted. If you have a child who's under 1, which means that they weren't old enough to have started the vaccine series yet, or if you've not been vaccinated, then certainly being exposed to someone with measles could be life-threatening. If you're going to be traveling out of the country, it is recommended that you ensure that you are protected. So international travelers, and now this includes people traveling to high-income countries. So before, it was really, certain countries that still had a fair bit of measles circulating, and now we can just add these high-income countries because that is not, unfortunately, having access to good information and good vaccines is not, unfortunately, anymore the end all be all, and people are actually choosing to go unprotected, even in these high income countries. So now we just have to take greater precautions. So, for instance, even if you're going on a trip to the UK now, you would need to make sure that you are covered. If you have a baby who's under 1, you actually can get the MMR series started early. So at 6 months, you can start. So you're planning on traveling with a baby who's under 12 months. This is something where you're going to want to go ahead and get them vaccinated. And they will need to be revaccinated with 2 more doses. So, starting early, does have that caveat of it maybe not being as great as starting after 12 months. But if your child's going to be exposed, then better to be on the safe side. So, unfortunately, it looks like we are in a time where there are certainly pockets, at least, of places where vaccination levels have dropped, such that if a new case of measles is introduced, it can spread, and this is putting folks at risk. So really, at this point, it is about making sure that those who are eligible for the vaccine are getting the vaccine. If you're really not sure, you can talk to your doctor about it and perhaps get your titers checked. And I think that in the event that there's an outbreak near you, um, folks are going to have to kick it into gear. The public health department is going to have to start doing these outbreak investigations, notifying people. And in most places, that's exactly what is done. So it's just something to keep alert for. And it's possible that some of the recommendations will change as time goes on. So we will just keep an eye on that. But really, at this point, any rash, and the typical rash, unfortunately, doesn't show up until after you're already contagious, but it typically starts from the head and just kind of makes its way down. But really, if you're not sure, call your doctor. And of course, doctors, nurses, daycare providers, people who work in different types of facilities need to brush up. What does the measles rash look like? Because we all need to act quickly to kind of limit the damage that can happen from this. So now I want to touch on monoclonal antibody treatment. I know we've talked about monoclonals here many times, but it's been a little while since we've actually had a monoclonal antibody that was available on the market. So first, real quick review, what are monoclonal antibodies? So they're a type of protein that is made in the lab, and they're designed to bind to certain targets like antigens, which antigens are basically anything that would potentially cause an immune response in the body. So monoclonal antibodies can be made to bind, and they're very specific. They're made to bind specifically to the thing that we're worried about attacking the body. So it could be a toxin or an infection or even cancer. And there's actually quite a lot of amazing innovations that involve monoclonal antibodies, like even using them to carry treatments directly to cancer cells because they can be very specific and bind to proteins that are on the surface of those cells. And in this case, monoclonal antibodies target the spike protein on the surface of SARS-CoV-2 virus. And for a while, we had monoclonal antibody treatments, which was great. It was a helpful treatment option. It actually came out long before Paxlovid did. And it was great while it lasted. But unfortunately, SARS-CoV-2 does what it does, which is mutate. And those monoclonals were no longer a match. And since then, we have not come out with updated ones for treatment. And then we still don't have them. The other thing that we had, which came out in December of 2021, was Evusheld, which is a monoclonal antibody that got emergency use authorizations from the FDA for preventing COVID-19. And this was authorized for those 12 and up with moderate to severe immune compromise due to either a medical condition or medications that suppress the immune system, and even for those who could not take the COVID-19 vaccine. But unfortunately, in January of 2023, a little over a year ago, the FDA revoked Evusheld's authorization for emergency use because SARS-CoV-2 did too much mutating. So the variants that were circulating at that time basically made Evusheld inactive against SARS-CoV-2. But good news, just a few days ago on March 22nd, the FDA issued EUA, emergency use authorization approval of Pemgarda for pre-exposure prophylaxis, or in other words, prevention for immunocompromised individuals 12 and up. And this is the first option we've had since Evusheld's authorization was revoked. So this is something that has to be administered ahead of time. So you cannot wait till you have COVID. In fact, if you already are infected, you're not eligible for this. So this has to be done ahead of time. And then it provides protection. And I think it remains to be seen how long this protection is going to last, but the authorization states that you can receive this treatment every 3 months. So it's authorized to give every 3 months. And according to the news releases, it is supposed to be available in the US any day now. It will be on a limited basis because apparently demand for these things hasn't been high in the past, which is a little frustrating because actually access has been very, very challenging. So I think it's hard to tell that if demand is what demand is, if it's hard for people to get it, and a lot of people don't know about it. But nonetheless, it looks like they will be sending them out in sort of smaller batches and trying to really get the people that are at greatest risk to be the ones who receive it. It is demonstrating activity in the lab against the JN.1. So remember, that's what we're mostly dealing with now. And it is administered IV. Now, the biggest adverse reaction that they saw, the most common and the most concerning, was a severe allergic reaction. This was in less than 1% of those who were treated. So 4 out of the 623 participants in the clinical trial experienced anaphylaxis. So this comes out to about 0.6%, or a little more than 1/2 of 1%. So it's a small percent, but it's also a small sample size. So only 623 participants, which is a very respectable, decent number of participants in a trial, but it's probably not big enough for us to really establish the rate of anaphylaxis. In fact, when we first got the mRNA vaccines, we actually were concerned that this was going to be a bigger issue than it actually turned out to be. So after giving millions upon millions, then we were able to really establish that it was much lower than we initially thought. But I'm not sure when we'll get to that point with this particular medication. So at this point in time, it's something that we need to absolutely be alerted about. The treatment had to be discontinued in those 4 patients. They all had to be treated for anaphylaxis, so like Benadryl and epinephrine and so on. They survived, and it is a pretty small percent, but again, something we'll need to be cautious about once this is really deployed in the population. And it's important to note, again, this is only for pre-exposure prophylaxis. So this is not for treatment. It's not for post-exposure prophylaxis. So at one point we did have monoclonals available. If you got exposed, you could go run out and get some monoclonals and keep yourself from progressing on to COVID. We don't have that anymore. We actually have nothing for post-exposure prophylaxis. It's also not authorized for the treatment of long COVID. There's nothing authorized for the treatment of long COVID, as we know. There was a very small yet significant case study that I reported on a few months ago when I did a pretty comprehensive overview and update on long COVID. I've linked that video in the post in case that's something you're interested in, kind of while we're on the topic of monoclonal antibodies. So I'm looking forward to Pemgarda becoming available. We still don't know some of the details. I still don't know some of the details. How accessible is it going to be? The place that we used to send our patients to get infusions is unfortunately no longer open. And so I'm sure will be trying to find where we can get our patients access to Pemgarda. Most likely hospitals and other infusion centers will have it. Hopefully it's going to be easier to find in infusion centers, because the big problem with trying to get monoclonal or remdesivir treatment even now for COVID is that these are the people who need it are sick with COVID. They're positive, they're contagious, and most infusion centers treat people for cancer and other autoimmune diseases and other things that can make them immunocompromised. And so the last thing you want is someone contagious coming in. So that's been a big issue. So I'm really, really hopeful that that will not be an issue here, because as I said, this is for pre-exposure. So you don't have COVID when you get Pemgarda treatment. So we'll keep an eye out for that and hope for the best there and advocate for the best there as well. We also don't know when it will get its full license. So once it gets its full biologics license, then there's a little bit more flexibility perhaps on how it is used. So there could be providers that opt to try it for the long COVID patients if and when it receives its full license. But there's, things can happen between now and then. SARS-CoV-2 can keep mutating. So at any rate, we'll have to keep an eye on that. But for now, it really is going to be restricted to what it says in the emergency use authorization, which is pretty limited to pre-exposure prophylaxis for people with moderate to severe immune compromise, which could be from a condition or from a medication. We also, as I alluded to, don't really know how effective this is going to be over the long term. This is one of those things where we have to give it time to see how it's working. This is essentially still being studied. And I think we will learn more as time goes on. And I have linked the fact sheet in the post, which has some good information for patients. I also linked the FAQs. The FAQs are actually very good and very detailed, and they talk about specific examples of what types of conditions this can be used for. That's definitely worth taking a look at. And in general, regarding monoclonal antibodies, I do still remain hopeful. I'm hopeful for a couple things. One is that we'll ultimately come out with a variant-proof monoclonal for prevention and for treatment and for post-exposure prophylaxis. There is some hope out there. I reviewed a very promising potential monoclonal antibody in a prior briefing. I've also linked that in the post in case you're interested, because it's important to keep hope. And there are some amazing things being, worked on. And so I think it's for those of us who are following all of this, I think that could be helpful to know that there's some things on the horizon. I'm also hopeful that at some point this can be a treatment for the subset of long COVID patients who might benefit, which means I also am hopeful that we figure that out. Who does it benefit? Who will it benefit? But I mentioned that case study, linked to the prior briefing is in the post. But these are sort of small scale things that we have right now. But there's a lot of study underway, and I know that we'll be learning more as time goes on. So In summary, we are slowly but surely coming out of peak respiratory virus time. Certainly, COVID continues to circulate. Flu and RSV are coming down. There's still, of course, other viruses, parainfluenza, human metapneumovirus, other things that are out there. But flu and COVID are really the ones where we have specific antiviral treatments. So if you are at risk of a bad outcome, you should know that now so that you can stay prepared. This means that you would need to get timely tested and treated in that case, since we know that with antivirals, the earlier the better. And in most cases, you really need to start within 72 hours or up to 5 days. And here are the approved SARS-CoV-2 treatments. And flu, COVID, and now RSV are the respiratory viruses that we have vaccines for. So we are kind of at the tail end of flu and RSV season, but it is worth making sure that you stay up to date on those vaccines and if it's indicated for you. And remember that an additional vaccine is now recommended against SARS-CoV-2 for those 65 and up, and meaning a springtime dose or a dose now, so at least 4 months after your last dose for those 65 and up. And an additional dose was already the recommendation for those who are immunocompromised. So this is essentially, I think, moving us into a twice a year vaccine for those considered highest risk, so those immunocompromised and those 65 and up, and annually for everyone else 6 months and up. And that is, of course, specific to the United States. And now we have a pre-exposure prophylaxis for COVID. In other words, prevention is now becoming available for those with moderate to severe immunocompromise. And once again, some examples such as those who are on cancer treatment, or people who've received a transplant and they're on anti-rejection medications, or those who are on high-dose steroids, just to name a few. And again, there's more specifics in the linked FAQs. And so for now, we want to keep up our best practices for preventing the spread of all respiratory infections, but especially COVID and long COVID, as we're still really in the early stages of understanding all that we need to understand. So we're going to want to stay up to date on vaccination, wear a high quality filtration mask like a KN95 or N95 when you are around others, especially indoors and especially where there are crowds, even outside. And gathering outdoors is almost always safer than indoors. And when you're indoors, we're going to want to pay attention to ventilation, open a window, open a door, check out the ventilation and filtration system in your indoor environments. You can monitor this with the CO2 monitor. It's a decent proxy. And we're going to want to test, isolate if you are positive, get treated in a timely fashion if you are eligible. Remember, enough to detect is enough to infect, so we don't want to spread it around to others who might not do well if they get SARS-CoV-2. Remember, we are still losing too many people, and too many people are still being hospitalized, and too many people are ending up with long COVID and post-COVID impacts. So still a great strategy to avoid infection and reinfection, because catching COVID once and doing fine is not a guarantee about the next time. And every infection is a new opportunity, maybe even a compounded opportunity. We still have more to learn here. But it certainly is a new opportunity for long COVID and post-COVID impacts. Please don't push yourself. Allow yourself the time you need to fully recover. And if you are someone who should be treated, if you get COVID, you should know that now. If you don't have a primary care provider, please get one. Don't wait until you need them to try to reach them. Go see them. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol. Establish a relationship with your primary care provider. We all deserve to have that healthcare provider who knows us and who is in our corner. And in addition to all that, remember to eat a balanced diet, incorporate fresh foods, avoid sugary drinks and sugar in general, avoid processed foods, get some regular physical activity unless you don't feel well. In that case, please get your rest. and manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we will see you again next Tuesday at 10 a.m. See you then.